Greetings, I'm Dr. Karl Nath, the Editor-in-Chief of Mayo Clinic Proceedings, and I am pleased to welcome you to the multimedia summary for the journal's April 2022 issue. There are 3 articles that have been selected as our Editor's Choice or Highlights articles this month. The Editor's Choice this month is an original article entitled Healthcare Expenditures Attributable to Primary Care Physician Overall and Burnout-Related Turnover, a cross-sectional analysis. It is authored by Dr. Christine Asinsky from the American Medical Association in Chicago, Illinois, and colleagues from Stanford University in Palo Alto, California, from Mayo Clinic in Rochester, Minnesota, and the University of Notre Dame in Notre Dame, Indiana. Continuity of care is beneficial in numerous ways that include improved patient well-being and outcomes, lower rates of emergency room visits and hospitalization, greater patient compliance with prescribed therapies and management, greater patient contentment with approval of their care, lower mortality, and reduced medical care costs. Continuity of care has an impact even in hospitalized patients in whom outcomes may be better when patient care is provided by hospitalists with a less interrupted work schedule. Continuity of care may be disrupted by several factors, including physician turnover. Asinsky et al. Assess the healthcare costs imposed by physician turnover in this article. Drawing upon data from the American Medical Association Physician Master File, published information regarding Medicare costs, and estimates for non-Medicare patients, these authors determined that healthcare costs ascribed to primary care physician turnover approximated $90,000 in the first year a primary care physician left practice, with total annual excess healthcare costs from such turnover approximating $1 billion in the first year. Healthcare costs from physician turnover, specifically caused by physician burnout, exceeded 25% of the total annual healthcare costs. The disruption of continuous care thus not only deprives patients of the benefits that accrue from continuous care, but also imposes a substantial financial burden on the healthcare system. Why healthcare costs are less with continuous care is an important question and one discussed by Asinsky et al. A plausible proffered explanation resides in that sense of trust engendered by and which subsequently informs a long-term engagement between patients and their physicians. Trust-based partnerships are the cornerstones in healthcare services for a number of altruistic, mission-based, and compelling reasons, as discussed by Berry et al. Last year in Mayo Clinic Proceedings. Trust between patients and their physicians, as engendered by continuous care, likely influences diagnostic evaluation, patient referral, management, hospital admission, and other aspects of patient care, such that healthcare costs are inherently less. With physician turnover and a trust-based relationship yet to be developed with a new physician, healthcare costs attendantly increase. Physician turnover, especially due to burnout, are addressable issues in current attempts to curtail the continuous increase in US healthcare costs. The first highlight article in the present issue of Mayo Clinic Proceedings is an original article entitled An Electronic Health Record Compatible Model to Predict Personalized Treatment Effects from the Diabetes Prevention Program, a cross-evidence synthesis approach using clinical trial and real-world data. It is authored by Dr. David Kent from Tufts University in Boston, Massachusetts, and colleagues from the Allegheny Health Network in Pittsburgh, Pennsylvania, Mercy Health in St. Louis, Missouri, Erasmus MC University Medical Center in Rotterdam, the Netherlands, and the American Medical Group Association in Alexandria, Virginia. Prediabetes occurs in approximately 1/3 of the US population, and either lifestyle modification or pharmacotherapy may interrupt its progression to type 2 diabetes. The article by Kent et al. Describes an electronic health record, EHR, compatible model that assesses the individual risk for diabetes and how such an assessment may aid in deciding whether preventative interventions may be especially warranted. This study was predicated on the following considerations discussed by Kent et al. First, the Diabetes Prevention Program study by Nola et al., published in 2002, clearly established the efficacy of either lifestyle modification or metformin in reducing the risk of occurrence of type 2 diabetes. However, the risk of occurrence of type 2 diabetes varies markedly in pre-diabetic subjects. Uncertainty thus surrounds which patients would benefit from preventive interventions, the latter less likely to be of value in low-risk patients. Second, there are relevant issues as regards preventive interventions. Intensive lifestyle modifications require healthcare resources and patient compliance, while the use of metformin may be attended by significant side effects. Third, extrapolation of findings from randomized clinical trials to patients in the real world may be challenged by heterogeneity in this patient population and in their response to treatment. Kent et al. Used the Optum Labs Data Warehouse Observational Database to develop and validate a risk prediction model based on 11 variables. These variables included age, sex, race, smoking, BMI, hypertension, systolic blood pressure, HDL cholesterol, triglycerides, fasting glucose, and hemoglobin A1C. The predicted 3-year rates for diabetes based on this model faithfully correlated with the observed rates. The Optum Labs data warehouse model was then applied to the Diabetes Prevention Program data. There were several notable findings that included the following 3. First, the effect of lifestyle modification tended to be comparable across all risk groups, whereas the treatment effect of metformin increased as risk increased. Second, the 3-year predicted risk of developing diabetes was 9%, 6%, and 3.9% for usual care, metformin therapy, and lifestyle modification, respectively. And third, lifestyle modification or metformin, singly applied, prevented more than 50% or 70% respectively of preventable diabetic cases in the highest risk quartile of patients. This analysis and modeling by Kent et al. Are important and timely, especially as they culminate in a valuable EHR-compatible tool. This smart app automatically predicts individual risk for type 2 diabetes. It identifies those high-risk patients for whom preventive intervention would likely interrupt the development of type 2 diabetes, and it promotes shared decision-making with pre-diabetic patients regarding the prudent course of their management. The second highlight is an original article entitled Association of Physical Activity with Primary Cardiac Arrest Risk in the General Population, a nationwide cohort study of the dose-response relationship. It is authored by Dr. Moon Nayoon Jin from Inji University College of Medicine in Seoul, Republic of Korea, and colleagues from Yonsei University College of Medicine in Seoul, and Cha University in Seongnam, both in the Republic of Korea. The health benefits of physical activity are indisputable and diverse, ranging widely from reductions in all-cause and cardiovascular mortality to salutary effects on irritable bowel disease and depression. However, still to be fully resolved are such issues as the level of physical activity that exerts the optimal beneficial effects, the nature of the relationship between health benefits and a graded increase in physical activity, and the clearly troubling issue whether too much physical activity may prove damaging, indeed fatal. As regards the latter, vigorous physical activity has been linked, albeit relatively rarely, to sudden cardiac arrest. The study by Jin et al. Addresses such issues using primary cardiac arrest as the primary outcome. These authors utilize the Korean National Health Insurance Service National Sample Cohort Database. This database includes a national health screening data set that compiled data on questionnaire-derived physical activity. Physical activity was estimated as a metabolic equivalent task, abbreviated MET, and ranked into 7 levels of increasing activity, with the units being MET hour per week, that reflected multiples of the WHO and the United States recommended minimum physical activity per week, namely 7.5 MET hour per week, or 150 minutes per week of moderate intensity, or 75 minutes per week of vigorous intensity physical activity. The data obtained from more than 500,000 participants in this screening program from 2009 to 2014 demonstrate the following. First, compared with inactivity, physical activity was associated with less primary cardiac arrest, with beneficial effects discerned at levels of physical activity below the recommended minimum of 7.5 MET hour per week, and at all 7 levels of activity, including physical activity greater than 37.5 MET hour per week. Second, these associations generally held true irrespective of age, sex, BMI, and relevant comorbidities. Third, maximal benefit was observed with physical activity in the range of 15 to less than 22.5 MET hour per week. Fourth, primary cardiac arrest was not increased when physical activity was even greater than or equal to 37.5 MET hour per week, irrespective of lifestyle, risk factors, or cardiovascular disease. And fifth, increased physical activity associated with diminished all-cause and cardiovascular mortality. These findings are important and reassuring because they underscore the beneficial effects of physical activity, and they demonstrate that the highest levels of physical activity in this study were not associated with an increased risk for primary cardiac arrest. You can access these highlights and editor's choice articles free of charge during the entire month of April. Please visit our Mayo Clinic Proceedings website at www.mayoclinicproceedings.org, where you'll find links to our social media by clicking the buttons at the top of the homepage and at the bottom of any page to follow us on Facebook, Twitter, and YouTube. On our YouTube channel, you'll find full-length author interviews called Insights, 60 seconds video article synopses, and our Mayo Clinic Proceedings issue summary and author insight podcast recordings, which are available from our website on our homepage, as well as through iTunes. You will also find our online-only features and many news stories posted in the News from the Editor carousel on our website homepage that are based on articles published in Mayo Clinic Proceedings. And finally, you will see other free content, as well as articles published online in press. As always, we greatly thank you for your interest in and your support of Mayo Clinic Proceedings.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.